Bismillahirrahmanirrahim. I'm Dr. Jalaluddin, working as head of cardiology department, Bolan Medical Complex Hospital. I think starting from the basics of intervention and now coming to the complex cases, this session is going to deal with the cases that every intervention cardiologist likes to be good at. So in this session, we're going to have talks on complex coronary lesions. How do we manage these lesions? Before I call upon our speakers, I know that during all these talks we are going to have masters on bifurcation, on left main, on bony vessel, calcified vessels, on CTOs. So before I call upon our first speaker, I would like to ask our panel of experts to come and come on the seat. Dr. Mohammad Anjum. Do we have Dr. Mohammad Anjum? Dr. Abdul Ghaffar Khan. Mohammad Kashif Sheikh. Sayyid Fasi Ahmad Hashmi. Rafiullah Jan. Dr. Sayyid Abdul Bari. Dr. Usama Munir, Dr. Awais Ahmad Nizami, and Dr. Ahmad Khan coming all the way from Australia as a panel of experts. Dr. Ahmad. So all the speakers are requested that to stay confined to the given 10 minutes time so that we can finish in time. So the first talk is going to be on bifurcation stenting. We know that bifurcation stenting is the most difficult part of PCI, and around 20% of cases that we deal in our day-to-day practice, they're having somehow bifurcating lesions. How to manage, what are the tips and tricks of bifurcating lesions? Dr. Muzaffar Ali is going to present on bifurcating lesions.
Thank you, Dr. Jalal. Appreciate the opportunity of presenting tips and tricks in bifurcation PCI. So, I have no conflict of interest to declare. So, why bifurcation PCI is important? It's account for 15 to 20% of the PCI and have variation in anatomy as well as dynamic changes in anatomy during treatment in terms of plaque shift, dissection, and believe me, no two bifurcation are identical in fact. So left main bifurcation also is different because of a T-shape angulation, large main vessel, caliber discrepancy, calcification, osteal involvement, and side branch, obviously circ is not small, and there are 10% of the trifurcation lesion also. So that's why the left main is PCI is special because there is impact on stenting technique, increased caliber discrepancy, part is essential, and stent design is there very essential, and the bifurcation angle matters. Aorto-osteal involvement actually lead to increased elastic recoil, and risk of longitudinal shortening is also there, and calcification especially is when there is calcification, the lesion preparation is key. So some basic principle of bifurcation PCI, when you are choosing the stent, especially for the main vessel, always choose according to the distal reference diameter. As well, we'll choose according to proximal, then there will be carina shift, and this is incorrect placement. Second picture, and the proximal is the correct placement. So what about the port? Port is essential, should be performed routinely during the bifurcation procedure as it optimizes the stent deployment, opposition, and restore the fractal geometry of the vessel, especially the proximal segment, and it actually lead to the proper optimization and avoid the sub-stent wire placement. So final KBI is also important, optional for provisional, but mandatory for complex two-stent strategies. And what is the selection of the balloon short and NC balloon size according to distal reference diameter. And side branch should be inflated first and then the main vessel branch, but there should be the simultaneous deflation. Some people actually believe in long inflation, at least 20 to 30 seconds. And look at the first picture when the single stent was placed in the main vessel. And there is a pre-KBI high shear stress proximal to the branch vessel. But after post-KBI, look at the lower shear stress opening of the strut toward the main side branch in after final casing balloon inflation. So, side branch crossing, a controversy whether to cross proximal or distal. When you are performing a DK crush, it is usually cross the proximal strut, but the all other technique, it is better to cross the distal strut to preserve the carina. So, here is the, when you actually perform the bifurcation PCI, when you call it as a clinically relevant side branch, when the side branch length is more than 73 millimeter and it should supply at least 10% of the myocardial mass, then you call it as clinically relevant, then you can switch to bifurcation strategy. Otherwise, provisional approach is better. So, Medina cholesterol, you all are aware, when proximal and distal vessel and the side branch is involved, and complex when there the lesion is extended and the side branch beyond 10 millimeter. So, here are the strategy when there is bifurcation lesion, you have to think whether the side branch need to be preserved, it is sizable, it is meaningful, or clinically relevant. So, then go for the planned 2 stent upfront strategy, otherwise provisional strategy is better. Or when there is a high likelihood of side branch sacrifice after PCI, then you can opt this 2 stent strategy. Otherwise, it's better to go for the provisional strategy. So once you decide it's the 2 stent strategy, then look at the angle. If it is more than 90, then it is better to go for the T stent or tap. If it's less than DK crush is time tested strategy. So guideline also support then stent implantation in the main vessel only, followed by the provisional balloon angioplasty with or without stenting of the side branch is recommended for PCI bifurcation lesion is class 1 indication. And look, the double kissing crush technique, DK crush, still is coming in the 2B classification when there is upfront 2 strategy is required. This is also EBC consensus. So, sometimes there is a difficulty in rewiring the side branch, then you can help in making different angles of the wire tape, but also you can help the macrocatheter, especially like Supercross or sometimes Suzuki with side pore also help you in navigating the side branches. So, provisional stenting is the most commonly used strategy, step by step. These are the, you wire the main vessel, cartoonic picture, and the side branch, then put a stent from main vessel. And look, part is a part and final part, and in between there is KBI is essential for good result. So here are some cases. This is first case. Patient actually was having presented infraposterior MI, and there was, after doing the stenting of the right vessel, then we look at the left main, there was critical left main stenosis. There was also mild disease in mid LAD, but after doing IVAS, the calcification was, arc was less than 80, and the distal LAD lesion was, plaque burden was less than 50%. So we planned left main stenting from left main to LAD, putting a wire in circumflex, and after KBI, in fact, we preserved the anatomy and also saved the second stent in circumflex. This is the final picture. Ostium circ is looking great, and this was also further confirmed by the IVAS, pre and post IVAS was also done on this patient. So look, calcification is less than 80 or 150 arcs, so we actually pre-dilated with NC 3.5 and then putting the stent. And we pull back the, I was from circumflex to left main, and there was a satisfactory result of the STM of the circumflex with an atherosclerotic burden less than 50%. So GSKBT is another popular technique. This is another gentleman coming with bifurcation lesion, and look at the side branch with simple bifurcation lesion, not complex, extending less than 5 millimeters. So we performed GSKBT by putting a balloon size to diagonal vessel 2.5 and with a 3 to 4 millimeter overlap in main vessel and then inflating the stent. And this was the result. This is part and this was the result. So both branches are looking great without any dissection in ostium. This diagonal and less than 50% residual in side branch. Another technique of Coulard. For Coulard, there the bifurcation vessel should be equal size and look at the angle, it is narrow, less than 90. So we performed Coulard. First principle is to stand the most angulated branch, the diagonal, and then LAD. This is the FKBI and part. This was the final result. So mini crush, another patient come to us who was having a left main equivalence situation and it's chest pain right after doing angiography. So we switched to mini crush and putting stent from left main to circumflex and then LAD. This was final kissing balloon inflation. So there was also a lesion in the side branch diagonal. So we actually balloon it and flow was preserved. This is the final picture. So another patient coming was with the bifurcation lesion. Here we use DK crush. These are all steps of DK crush. Summary, keep it simple and safe, limit the number of stent, respect the original bifurcation anatomy and try to reproduce it, aim for well opposed and well expanded stent with limited overlap and take home as provisional side brain stenting recommended for majority of the bifurcation including left main. Stent technique should depend on individual patient anatomical characteristics and apparatus scale. Elective two-stent strategy should be reserved for only patients who have complex anatomy. Thank you very much.